We produce these risk-adjusted reports, and we often send them over with not as much context, maybe as would be ideal for somebody who hasn't worked with this type of data analysis before. So I'm just going to kind of cover what the motivation is for why we do it, and also try to give you a little bit of an intuition for how we actually do it. Across the different parts of BMC2, vascular surgery, PCI, MISHC, we produce kind of slightly different versions of these risk-adjusted reports. So some of the stuff I'm going to cover, I'm not sure is always in the MISHC reports, but if you're looking at some of the other risk-adjusted reports, you might see them and you'll kind of understand that it all goes together. It's all part of the same thing, the same kind of stepwise methodology that we use. So to start out with the motivation, we want to give you an honest assessment as to how your site is performing. And we want to give you a sense of how you're performing in relation to the other sites across the state of Michigan. But there are some problems when we try to make these comparisons because it's not always apples to apples. The challenge is that different hospitals have different volumes of patients. They do more procedures than others. And some sites have a more complicated mix of patients than other sites. So to just give you a raw summary of the rankings of hospitals, quote unquote, as to where you stand compared to others is it's not straightforward. We want to take into account these other factors that make each site unique. So the example that I'm going to be using it's based on real data, real TAVR procedures for 30-day readmissions. So this first figure here is just without any type of risk adjustment whatsoever. This is showing each of these bars as a different site, and the heights of the bars represent the 30-day readmission rates. So the lower bars indicate that there are fewer readmissions, higher bars represent the most readmissions. Now, as I was saying, there's a lot of heterogeneity going on. So if we were to actually take into account the number of procedures, and I've added the number of procedures above each of the bars, you're going to see quickly that there are a lot of differences. So on the far left, the hospital with the lowest readmission rate, the number of TAVR cases that are considered in this analysis is 124. Meanwhile, on the far right, this is the site with the highest readmission rate. The number of procedures we're counting is only 22. And with 22, you really only need 3-4 people to be readmitted after 30 days before you suddenly have a readmission rate that's getting close to 20%. So again, this comparison isn't necessarily fair when you just happen to have a small volume and just get a couple of bad luck cases in a given year. So we want to account for that. The other thing that I was saying is that the patient mix in terms of complexity also varies from one site to the other. So what I've done with this graph here is it's the same graph as before, but I've taken a number of common comorbidities that patients present with, and I added them together and calculated what is the typical number of comorbidities amongst this set that I considered that the typical patient presents with. The lighter the colors, the fewer the comorbidities, the darker, the more complicated the cases. And again, this hospital on the far right has not only the bad luck of having a low volume, but also the bad luck of having a more complicated case mix. So we're already starting to see that. To say that this particular site is performing poorly compared to the others is really an unfair statement. So we want to come up with some type of way to make the comparison a bit more fair. In doing so, we take this 4-step approach to performing the risk adjustment. So in step 1, we take all of the patient data across all the sites, and we fit a statistical model. And that's averaging across all the people. We say, okay, given this mix of patient characteristics, what is the probability that a given patient is going to be readmitted within 30 days? So first we estimate that model, that's step 1. Step 2, and the basis of that model is essentially an equation where we plug in the patient characteristics, and out of that equation comes the probability of observing a readmission. Once we have each patient-specific probability, we can then aggregate that to the hospital level, and we can make this comparison we call an OE ratio. The O is the number of readmissions that we observe, The E, though, is what you would expect given the patient mix. So this OE ratio is already giving us a sense as to, are you seeing more readmissions than we would expect given your patient mix, or are you seeing fewer readmissions? Once we have this number, this OE ratio, we can then multiply it by the overall rate across all hospitals. And the result is a final number that says where you stand or what your predicted readmission rate is going to be, given the patient mix that you're seeing. So 3 is the OE ratio, but then we multiply it by the overall rate, and that gives us 4, your adjusted readmission rate. So it's not the actual readmission rate you have, it's what your readmission rate is after we account for the fact that you have a different patient mix than other sites. Now, this is kind of a lot of steps and a little bit of jargon being introduced to you early on a Tuesday morning. So I'm going to walk through these steps one by one to illustrate them for you. So the first thing that we do is we fit this statistical model, and this is what we see. We don't make you look at this. Your eyes will gloss over. You really won't know what to do with it, but this is what we see on our end. This is the model that we fit. It's called a logistic regression model. The outcome that we're trying to predict is readmission. And then the variables that you see presented here, these are the things that go into that model, the patient characteristics that we use to determine if they're a high risk of readmission or a low risk of readmission. So we have this column, it's called an odds ratio. That tells us if the person, if it's greater than 1, it means that as that person's age increases, for example, they're more likely to have a readmission. If they're male, they're more likely to have a readmission. If they're a smoker, they're more likely to have a readmission. And if it's less than 1, it means that they're less likely to have a readmission. So we get these odds ratios, and there's a lot of numbers, but we also know that in any data set, there's noise. Even if, say, find one that's kind of significant here, the KCCQ summary score, even if the effect of that is actually 0, just based on noise in the data that we get, we're going to get a number that's different than 0. So we look at this final column, this p-value, and that lets us know if it's less than 0.05, which is just a convention statisticians have used for over 100 years. But if it's less than 0.05, this p-value is less than 0.05, we say, aha, there's a signal here. It's more than just, we can probably rule out that it's just noise that we're seeing for this effect, and it's actually something that's real that we want to consider. Depending on the risk-adjusted reports that we send out, I don't think we do this for MISHC, but we do definitely for vascular surgery. We'll actually present you a little bit more information on the outcomes or on the model. We don't give you all those numbers that are confusing to look at, but we might present to you which variables were significant, which had that p-value small enough for us to say like, oh, there's actually something here. So in this case, you can kind of see that the variables that matter, they're pretty much kind of what you would expect. KCCQ score seems to play a role. History of AFib, if they're on dialysis, is always a big predictor. So we can see here, and we might present this information to you or not. I think in the MISHC reports, we just tell you what variables go into it. We don't tell you what's important, but that information can be gleaned. So this is step 1. We now have fit this statistical model. We now have this equation, and we can take any patient that we come across, and so long as we have data on all of these variables, we can use that information to get a probability that specific patient is going to be readmitted. So we have our statistical model. Our step 2 then is to actually take that step, and for each individual patient, based on all the data that we have, determine what their probability is of actually being readmitted. This table here, it's not real data, but it's a sample data of what this actually looks like. So we have one hospital, we'll call it Hospital A. We have 10 patients. That readmission column, it's a 1 if they were readmitted, it's a 0 otherwise. And that's actually what happened. But for the probability column, this is what we get from our model. So the closer that probability is to 1, the more likely they are to be readmitted. And the closer it is to 0, the more likely it is that they won't be readmitted. We have this information now for each patient that we've gotten from the model. We now have a probability for each patient, and we have what actually happened with that patient. So now we can do step 3, where we can take that information and calculate that OE ratio. That is, the patients in your hospital, are they being readmitted more than we would expect? Or are they being readmitted less than what we expect? Or is it pretty average. So this OE ratio, it's really nothing more than we take the sum of all the patients in the hospital of their readmissions. Remember, they're ones and zeros, so we just add up the ones. That's the number of readmissions. And then we add up the probability, and this is the expected number of readmissions that we would expect to see if we had given this patient mix. So we just take the ratio of that O sum and that E sum. In this case, it's 3 over 5.4, and that gives us this value of 0.555. So interpreting this OE ratio, if it's less than 1, and in this case, it is less than 1, that means that the hospital has fewer admissions than what we'd expect. This hospital is performing quite well when that OE ratio is less than 1. If it's greater than 1, though, then it means that there are more readmissions than what we'd expect given the patient mix. And if that's the case, then we would want to sort of revisit or maybe take a closer look at what's going on at that particular site. There is, of course, uncertainty in these estimates, and that uncertainty is driven in part by the volume, the hospital volume. So in some of the risk-adjusted reports that we present, I think in the MISHC we might skip this step, but it goes into every single risk adjustment analysis. We have this OE ratio, and then we also calculate confidence intervals around the OE ratio. And these confidence intervals are driven in large part by the volume. The more volume you have, the more information we have and the more certain we can be about your hospital's performance. If you have fewer observations, fewer cases, then it's harder for us to confidently say what your site's performance actually is. So we can take those OE ratios and we can calculate confidence intervals around them. And you'll see that we have confidence intervals that are narrow and confidence intervals that are wide, again, representing how much volume there is at that particular site. And I have in this graph here, there's a horizontal line at 1. And I said, if it's above 1, it means you're doing worse than average. And if it's below 1, you're doing better than average. So what we can do with these confidence intervals, and we can see which ones of these actually are bounded away from 0. They do not, or from 1, they do not include that horizontal line. So we look at sites 1 and 2 on the far left here. Those sites, not only do they have OE ratios that are less than 1, but their confidence intervals, we're quite confident that their performance is better than average. Most of the hospitals, they're varying OE ratios, but most of them have confidence intervals that include that 1. So even most of these hospitals that have an OE ratio greater than 1, we would say, okay, you're performing a little bit worse than average. But given the site volume that you have, we are not going to say that it's we would say statistically significant, or practically speaking, it's not something that you necessarily need to be terribly concerned about. You always want to do better, but we're not saying that you're doing something wrong here. We're just saying that given what we see, and it's not a lot that we see, we don't have enough site volume to be able to say with confidence, but given what we see, there's room for improvement. There's only 1, maybe 2 cases that case number 24 or site number 24 is a little bit above the line. Site number 27 is above the line. Those are sites where they're doing they have significantly more readmissions than what we would expect, given the volume and given the patient mix that they have. Those are sites that we would maybe want to look at more closely and see if there's anything that we could do to help improve performance. We sometimes also present this slide. This is my least favorite slide because I don't think to the average person it doesn't make a lot of sense. But there is a logic to it once you understand it that can be helpful. So what we plot here, the lines that are listed as confidence intervals, those are just different levels of precision that you can use. Being the most generous, we'll use the 99% confidence interval at the top, and then also the solid line towards the bottom. And what you'll see is along the bottom, we have the number of procedures. So you can see that our confidence intervals, and this is kind of a different way of presenting sort of the same information on the prior slide, insofar as these confidence intervals are wider when the number of procedures is lower. But the way that you want to interpret this graph is you would locate what your site is, and if we give you this graph, we would highlight that site for you, and we would just want to make sure that your site is performing within these confidence intervals. Now, this is actually different than the prior slide because this prior slide was the OE ratio, but for this slide, we've actually taken that OE ratio and we've done that last step and we've converted it into the risk-adjusted readmission rate. And that's what's on the y-axis. Again, this is, I think, is the least intuitive graph, but if you do encounter it, all you really have to do is find your site and make sure that you're inside those confidence intervals. Much more intuitive, and this is what I think is presented in the MISHC reports, is we take all of the sites after we perform this and after all these steps, and we've calculated this adjusted rate. This is a number that can be interpreted like a readmission rate. It's not your actual readmission rate, but it's your readmission rate adjusted for the fact that you have a different patient mix. And so you can look at where you stand on this particular graph. And again, we present it with confidence intervals. And again, we're presenting it, we have this horizontal line that's the average readmission rate after adjustment. And you can look at where you stand, rank ordered here. And then you can also take a look at this confidence interval. And so long as your confidence interval isn't bounded above the line, that is, so long as this confidence interval does not include that horizontal line, then you're good. And if you're on the far left here, where you're low, you're on the very low end of readmission, and your confidence interval is below the average, then you can pat yourself on the back for doing such a good job. As opposed to on the top end, we have 1 or 2 sites again that are performing a bit worse than what we would expect, and maybe could look at some things to improve processes. As a final way to get an intuition for what's going on, I have this little animation here, and this starts out with that very first graph that we looked at. So when you see the bars where it started out, we're getting back to it. You see right here, this is where we started. These are how the hospitals were before we did any risk adjustment. And then you see them shift, and these shifts are where they stand after we performed the risk adjustment. So again, that y-axis for the risk-adjusted readmission rates can be interpreted like a readmission rate. It's not the actual readmission rate, but it's your readmission rate for a comparison purpose where you stand vis-a-vis other sites, taking into account the patient mix. And you can see that there is some movement going on here. Some of the sites that were performing on the high end, you see that their bars start to go down a little bit, including that site at the very far right. Its readjusted rate is lower than what its unadjusted rate was. So we would have been wrong to say that the readjustment, the unadjusted rate is representative of what their actual readjustment rate is, at accounting for the different patient mix. It's still at the top. There's still maybe reason for concern, but there's definitely some change. So those are the steps that we use to go in to generate those risk-adjusted reports. And this is essentially, I think, the final product that you see. But the idea is that we want to give you a sense of where you stand compared to other hospitals, taking into account the fact that you have a different patient mix, and taking into account the fact that you have different numbers of procedures. The more that you have, the more certain we can be where you stand. And so you have a smaller confidence interval. And if you have fewer sites, then we want to make sure those confidence intervals are wide to say that, hey, even if you're at the higher end, your volume is low enough that that we can't necessarily say for sure that there's reason for improvement.